let everyone who's interested in our program get to know our program a little bit better by hosting these meetings. I think everyone should automatically be muted as our host, Noel, has already done that. Certainly if you want to see a little bit more about our program, we certainly have an Instagram account as well as a Twitter account. And so you can certainly also follow us on those and kind of get the ins and outs of what the residents are thinking, or cool cases they've done, or just the silly things they sometimes do by taking pictures of each other. So our agenda for tonight's meeting, obviously is an open introduction. My name is Tai Higuchi. I'm one of the reconstructive urologists here at University of Colorado. I specialize in male reconstructive urology and transitional urology. And so we also want to let you know about some future town hall events. Obviously, we're going to talk about our residency program overview. We're going to give a brief overview of the University of Colorado and then allow you to ask questions and answers. We'd ask that you ask your questions through the chat feature, and we'll certainly try and get through as many of those as we can. This evening, we have some residents on the line, so you can certainly ask residence-based questions, but please use the chat feature to ask any questions. So other opportunities to get involved to kind of know what University of Colorado Urology is all about. You certainly can attend future grand rounds. We have grand rounds currently every Monday from 7 to 9 a.m. Mountain Standard Time. If you'll check the University of Colorado website, there'll be a list of conferences. You're welcome to attend any conference except those that involve discussions of direct patient care, such as M&M, or certainly some of the more administrative meetings that we have from time to time. Those will not be listed on the sharing or on the website. So if you don't see a link to a meeting, there probably isn't one there that's available to you for that week. In addition, we also would invite you to attend our medical student education series. I know a lot of you probably have already attended them. Dr. Kukrasia and I, who direct our medical student education, have been holding weekly didactic sessions at 8 o'clock Mountain Standard Time, doing just kind of a potpourri of urology. We're excited to have some of our pediatric faculty joining us in the upcoming weeks. So we hope that we can continue this educational series as the academic year continues. And as I kind of mentioned before, we're going to have some future town hall events. So what we'd like to do in the upcoming is feature each site that we have available at the University of Colorado. That would include the Children's Hospital of Colorado, Denver Health Medical Center, the VA, and then at the end of the year or end of the summer, we would like to have, we have 5 CU students interested in urology. They're going to do an extended sub-I that we've offered to them, where they can do 8 weeks of sub-I at our home institution. And we wanted to open that up to you guys to talk to them about what they saw, what they experienced while they had during their sub-Is at the University of Colorado. So you can also get kind of an insider track. I won't be in that meeting, nor will Dr. Meacham. We definitely want you to have kind of an open opportunity to talk to like the students who actually rotated here and gone to school here. So with that, I'd like to introduce Dr. Andy Meacham. He's currently the Chief of Urology. He's been in that position since he's been here basically since 1990. He also serves as the Residency Program Director. He's an international expert in male infertility. He's served on multiple panels. He's a leader not only in our institution, but also nationally and internationally with the AUA. He's certainly one of the large reasons I came to the University of Colorado and have remained here, and also why I think my practice has grown into the reconstructive potpourri that I have currently. So with that, I'll stop sharing my screen and let Dr. Meacham start his presentation.
So Ty described his practice as a reconstructive, I thought you were going to say reconstructive powerhouse, a powerhouse. Oh. Potpourri, you know, is artistic, but doesn't sound quite as sort of sledgehammer. Let me do my screen share. We're doing this from 5 different locations. I've got significant confidence that this is going to work well, but let me confirm this. Is that coming across as a full screen share?
Looks
Yes.
great.
Perfect. It's a miracle. Okay, so thank you again. I want to emphasize what Dr. Oguchi said and what others have said. We're really very grateful to have you come and spend time with us this evening. We're very, very proud of the things that we have accomplished, the things we have to offer here at the University of Colorado, and we're really excited about getting an opportunity to share it with you. You know, it's interesting, this whole coronavirus thing has, as you're well aware, created a tremendous number of changes and challenges that we need to contend with. That said, it has really provided a lot of really exciting opportunities for us to get better at the virtual technology that we're using. And I think it's actually going to give a lot of the applicants, a lot of students finishing their medical school training opportunity to get to know programs in ways that they otherwise might not have. So we view this as a great opportunity. And again, we're very grateful to you for coming and spending time with us. This initial slide is a mountain climbing event we do every year. This was Mount Evans at 14,264 feet. There are 56 mountains in Colorado that are greater than 14,000 feet, so we refer to them as 14ers. There are a lot of people that try to climb all the 14ers. We as a division, and then we expanded it to the entire department, are working our way through. We are now at number 7, so we've got 49 to go. I'm sure Dr. Higuchi is going to be staggering up the very last one at like 103. He's got extraordinary stamina. This is us at the top. We got about 60 people at the top of Mount Evans. It was a lot of fun. This is actually me over here. This is Dr. Higuchi over here. And these are just sort of like random residents and attendings from our program. So a couple of words quickly or briefly about Denver, Colorado. I just have to tell you that I cannot imagine personally a better place or a nicer place to live than Denver. We have about 320 days of sunshine per year. We get about 11 inches of precipitation, which really sort of places us as a high desert in terms of our environment. The winters are actually pretty mild. It'll get cold and get down into the 20s, possibly the teens. Episodically, a little bit of snow falls. The snow goes away, the sun comes out, it warms up into the 40s, 50s, and 60s. Back here in the mountains, what happens is the weather moves from the west to the east, so the Front Range and the Rocky Mountains catch the precipitation, the snow falls up there, we go skiing, and then we continue to have nice weather down here. Summertime, it gets into the 90s, but the humidity, it typically runs in the 30 to 40% range. I did my training in Houston when I came here to look at this job, as Dr. Higuchi mentioned, in 1990. I went for a run, and I took my t-shirt off and I hung it over like a sort of a chair out on the balcony in the little hotel where I was staying. And usually in Houston, if you take off a sweaty t-shirt, it kind of gets like wetter over time. Somehow it creates moisture and gets soggier. I picked the thing up 10 minutes later, it was perfectly dry. And I just said, I'm going to move there and I'm never going to leave. And so far, I've sort of made good on that goal. The next, let me just see if I can get a clean advance here. Hold on one second. Sorry, I'm not advancing. And just give me 1 minute to get this to work. Okay, there we go. A couple more quick shots. This is Kit Carson Peak in the Sangre de Cristo Range, southwestern Colorado. Just another sort of typical scene from our state. This is another photograph. This actually was a PGY1 in the upper left-hand corner here that we were trying to recruit to the program. Ended up going into neurology, so we missed out on him. But this is, again, our team as the chair of surgery. This is us kind of trudging up the mountain, something we really enjoy. We do a lot of events together as a group throughout the year. We have a ski day that's formally designated. We have a number of other events. Those have sort of been stifled right now because of the COVID-19 social distancing. But by golly, next year, if we have to wear masks to the top of the darn mountain, we're going to do it again. I would say that the real backbone to our program, the real foundation, and the thing that I think most of our success derives from is our people. So our students, our residents, our faculty, and our staff are really just an extraordinary group. What I want to do is spend a little bit of time with you now talking about our faculty, introducing you to those who teach our residents, our fellows, and our students. This picture I'll point out is a photograph taken of a lake just north of Aspen that sits at the foot of the Maroon Bell. So this is Maroon Lake here, and then this is South Maroon and North Maroon, two more peaks that are greater than 14,000 feet, both beautiful climbs. I've done them as well, and they're really spectacular. As Ty mentioned, I'm the chief of the Division of Urology. I've been doing this job not since 1990. Actually, I was here 10 years before I took that position. I've been here as the chief since 90. I've been the program director since 89. This is just sort of a picture, a couple of pictures I couldn't resist putting up. This is our greater Swiss mountain dog. This is my wife, Darlene, who's a hospitalist. This is Ronan. Ronan weighs 140 pounds, which is about 30% more than Darlene. This is Ronan when he was 9 weeks old. Ronan grew up to become himself, and then he had puppies. And this is Onyx, who is 7 weeks old there and is coming. This picture was taken 5 days ago. He's coming home with us next week. So then we'll have like 280 pounds of Swiss mountain dog. We never asked the residents to take care of the dog. That would be cruel and unusual punishment, and so we never actually do that. But you get to meet him when you come over to the house for a barbecue and other things like that. But that's me. As Ty mentioned, I'm also the chief. I'm also the program director for the residency. I have two associate program directors who are just outstanding, Dr. Vijay Vimalakand and Dr. Simon Kim, but that's the graduate medical education team. Dr. Al Barkawi is a urologist who trained in Ireland and also in Jordan. He is a fellow of the Royal College of Surgeons. Al's practice is largely comprised of the management of prostate cancer. Al is one of the leading authorities in the minimally invasive treatment of prostate cancer. He uses cryotherapy as one of his primary modalities. He's published a number of international review articles on that and is really an opinion leader in the minimally invasive management of that disease. A great clinician, a great person, has a very, very strong research program also, and is a really outstanding teacher. Brian Caldwell is one of our 6 pediatric urologists. We hired Brian 3 years ago, which makes him like our 4th most recent addition to the team. Brian was identified last year for outstanding teaching by the residents. He's a great surgeon. He's just as nice a person as he looks like right here. I mean, Brian is just such a collaborative and interactive person. Residents love working with him. Patients really enjoy him. He practices pediatric urology part of the time. He's down at his primary location in Colorado Springs. Also comes up, operates rounds, teaches residents and fellows at the Children's Hospital, which is over on the east side of our campus. Jeff Campbell is another of our pediatric urologists. Jeff has been here about 12 years. Came from the University of Oklahoma before that. Jeff is the director of the Pediatric Urology Clinic over at the Children's Hospital, Colorado. Jeff is really one of the best technical surgeons that I've ever known in terms of doing the meticulous type of surgical procedures that are involved in pediatric urology, has extraordinary technique, also has really good organizational skills, and has really done a lot to develop and foster the growth of our pediatric urology ambulatory program. Also an outstanding teacher, has been identified by residents in the past in a formal fashion for his teaching skills, and is a tremendous contributor to the pediatric urology program. Nick Cost, gosh, it takes about a page and a half to describe the accomplishments of Nick, even though he's only been on the faculty about 4 years. Nick is a urologist who is board certified in urology, also has certification in pediatric urology, and is subspecialty trained in urologic oncology. So after he completed his residency, he completed a fellowship in urologic oncology at UT Southwestern and a pediatric urology fellowship in Indiana. And Nick is just an extraordinarily accomplished urologist for such an early stage in his career. I'm not going to say I agree with his choice of ties, but that's a sort of an individual choice. Nick has just recently become the director of the Pediatric Urology Fellowship. He achieved a institutional K award for research in bladder physiology and chemotherapy, and has completed that, and just now recently received K funding from the NIH, extending his research into the effect of chemotherapy in childhood on lifetime bladder function. As a superb surgeon, and Nick has really carved out what I'm going to say is a unique field of study in the entire country, which is to say he's combined pediatric urology and urologic oncology. He does extensive complex surgeries, including radical retroperitoneal lymph node dissections at our adult facility. also does complex pediatric urologic procedures at Children's, has a special interest in familial oncologic disease, such as renal cell carcinoma, familial patterns of renal cell carcinoma, has expertise in testis cancer, does sperm harvesting prior to chemotherapy in children at Children's Hospital, which is something that I collaborate with him on. So Nick is I will just say, one of the real rising stars in urology, adult and pediatric, and someone that has a tremendous future ahead of him. He's also just a really nice person and a great teacher. So Nick Costa is someone that we really, really value, and that I've just am continuously astonished at the extraordinary things he's done in a very, very short period of time. Austin DeRosa is one of now 3 community urologists we have that we've recruited into full-time practice at the University of Colorado. So what we're doing is, as we grow our clinical programs in the University of Colorado system, we have opened a number of smaller satellite hospitals, including one at Highlands Ranch, which is located in South Denver. Austin and his partner, David Sobel, have full faculty appointments. They practice general urology. Austin also has fellowship training in minimally invasive surgery and robotic surgery. Austin and David don't have daily contact with the residents and students, but they very regularly attend our teaching conferences and grand rounds. I have real confidence in the next 2 to 3 years, be having the opportunity to send residents down to Highlands Ranch to see how David and Austin practice, and also to get a sense of what it's like to be in community urology. We have 4 primary teaching hospitals, all of which are full tilt tertiary academic centers. So we're hoping and planning to develop the experience of residents will be able to spend some additional time in more of a community setting, because the way medicine is practiced there is similar, but it's slightly different. And since the majority of people who finish their residency do go into community practice, we think that'll be a real opportunity. Austin is also an extremely collaborative, extraordinarily nice person. Rodrigo Donalicio de Silva is the chief of urology at the Denver Health Medical Center. And I'll say a couple of things about Denver Health, but it's our large urban safety net hospital of around 600 beds. A tremendous experience over there for residents in trauma and acute care urology, as well as general urology and urologic oncology. Rodrigo's fellowship training is in minimally invasive urology. Among other credits to Rodrigo, he's done 2 Ironman triathlons in the last 5 years. He's also received Outstanding Teaching Award from the residents. The residents just continuously praise Rodrigo for his clinical skills, for his patience, for his willingness to teach, and the fact that he can do an Ironman and then come back to work and do a radical nephrectomy a day or 2 later. Pretty remarkable, actually, and just another real addition to our team. Brian Flynn is one of our more senior urologists. Doesn't look like it here. This picture is not from yesterday, but Brian still looks extraordinarily good for having been here for 16 years. Brian is the head of female urology, voiding dysfunction, adult reconstructive urology. Brian was the first urologist I recruited when I became the head of, actually the second. Fernando came at Denver Health, was the first. Brian was the second. Brian came from Duke, where he did his fellowship in reconstructive urology and female pelvic medicine and reconstructive surgery with George Webster. I'm going to say conservatively, Brian is now one of the top 10 people in the country in reconstructive urology in terms of reputation, in terms of clinical volume, in terms of expertise and academic standing. Brian has developed and is supported by Ty in this, Dr. Higuchi, probably one of the best, definitely one of the best, and one of the premier reconstructive urology fellowships in the country. We have 1 research fellow and 1 clinical fellow at a time. Brian is just a spectacular surgeon. He's also an extraordinary teacher. He has received the Outstanding Teaching Award more than once in the time that he has been here. Is never too busy to teach, spends a lot of time with residents, both in the operating room and out of the operating room. And, we can talk about this more, but we do have 2 fellowships, one in reconstructive urology, one in pediatric urology. We're very mindful that fellowships can be a real advantage. Fellows bring their own perspective. They're excellent teachers in the operating room. They have typically, and so far it's been the case with us in the 11 years we've had fellows here in recon urology, they have very good relationship with the residents, but we also understand that we have to be very prospective, and we have to be very mindful of the fact that residents and fellows both are there to learn surgery, and to make sure that we combine them in a way that that really strikes the best balance of expertise. It's been my experience that There's really nobody that's as good a surgical teacher for straightforward cases or the simpler part of complex cases than a fellow. They've just finished their residency. They understand the things that residents find to be challenges, and they can make extraordinarily good teachers intraoperatively. But our philosophy and our mission is that we are primarily here to teach residents, and residents will always be the ones that we give the greatest emphasis to in terms of the learning experience. So the relationship is, in my experience, always been synergistic, but we watch that very carefully to make sure that the fellowships enhance the resident educational opportunities rather than being a source of competition, say, for surgical experience. Tai Iguchi is someone who's developed a reconstructive powerhouse. He is a superb technical surgeon. Tai, in addition to his role as co-director of student education, is also the director of clinical operations for the urology program here, which is to say, Tai is someone that I lean on and rely on very heavily for managing clinical operations, everything from our inpatient service to working with me in the ambulatory arena, to helping to organize and stratify new clinical facilities such as Highlands Ranch and one that we just are opening in central Denver and Cherry Creek. So Tai has his hands full with all of those missions. He's also a great teacher, a great advocate for the residents. Dr. Iguchi has a special interest also in transitional urology. So he has established one of the largest programs in the country at the Children's Hospital. And you probably know this, but transitional urology deals with that patient population who have had complex care, frequently complex reconstructive procedures at a children's hospital when they're pediatric patients. Then they grow up and they get into their teens and early 20s. They transition at that point, or try to transition to the adult world. Many adult urologists don't have the same expertise in the complex reconstructive issues that face pediatric urology patients. So Dr. Iguchi is one of probably 4 or 5 people in the country that has really established robust practices in transitional urology, which is managing that population of patients that are older than pediatric populations or patients, but haven't really transitioned fully into the adult world. So it's a challenging but very rewarding area, and one that we're really pleased to have Tai leading over at Children's. Fernando Kim is a minimally invasive surgeon trained at Johns Hopkins, is at Denver Health, was the chief of Denver Health for many years. That has transitioned over to Rodrigo Da Silva, but Fernando is there teaching general urology, minimally invasive surgery, minimally invasive urology. An outstanding teacher, is secretary right now of the South Central section of the American Urologic Association. Dr. Flynn is a past president of the South Central. I'm a past president of the South Central. We emphasize regional and national urologic involvement, and our residents, as you'll see shortly, have been extremely productive in getting papers and posters accepted regionally and nationally, and that's something we're very proud of, and we certainly very strongly encourage and support. Simon Kim, one of our associate residency program directors, is just a really internationally recognized urologic oncologist. He's an extremely gifted surgeon. He has NIH R01 grant funding. He is probably the nicest human being ever to walk the earth. One of the residents on the call, Dr. Nadia Halstead, after Dr. Kim had been here, he's been here just going on 2 years, about a year and a half. When he'd been here about 6 months, I ran into Dr. Halstead and I say, so how's it going with Dr. Kim? And she said, oh my gosh, he is wonderful. She said, I know he's got a flaw. I know he's got a fault somewhere. We're watching him really close, but we haven't spotted it yet. I got to say, I haven't spotted it yet either. Simon is extremely nice, incredibly supportive, and just an extremely talented surgeon. And again, someone who I really value his input and his leadership in directing the urology residency training program as an associate program director. Janet Kukrasia. I don't know if Janet's going to be able to be here by the end of this evening session. She was going to be here. She's doing a renal cell carcinoma with a caval thrombus. Texted me saying, this is really going to probably take a while. And I was like, oh yeah, stop texting and go back to getting the tumor out of that guy's vena cava. Dr. Kukrasia is a urologic oncologist trained at MD Anderson. I've been here going on 2 years, just almost 2 years. And just an amazingly talented surgeon. A very, very skilled researcher, someone that has tremendous expertise in quality, safety, and process improvement, is leading a system-wide initiative now in the prevention of surgically related urinary tract infections, is someone that's certainly going to have NIH funding in the near future, I have no doubt, and is really a rising star in the field of urologic oncology with special emphasis on, again, quality, safety, enhanced recovery after surgery, and process of care. So someone we're super happy to have with us. Granville Lloyd is at the VA, Veterans Administration Medical Center, full-time. He is trained in minimally invasive surgery and also does a lot of general urology. He runs the robotic surgery program over there. Dr. Lloyd has a very strong research interest in clinical surgery, among other things, looking at the ergonomic aspects of surgery as it pertains to the health and the longevity of surgeons, something that's important to do, especially when you're parked all day in front of a robotic console. Also has a lot of other research interest in the management of prostate cancer, benign prostatic hyperplasia, and other topics. Granville routinely gets teaching awards from the residents. And this year, in the entire Department of Surgery, which is pushing 200 faculty, received what's called the Golden Apple Award, which is the individual that the medical students recognized in the entire department for their teaching excellence. So excellence in teaching when the competition is right at 200 additional faculty member or other faculty members says a tremendous amount. And we're very, very proud of Granville for getting that award. He is just an extraordinarily talented educator, not just for the residents, but also his students. Anna Malakina is a basic researcher. She is the chief of the basic research program in urology. Dr. Malakina is someone who supported Dr. Cost in getting his K funding in bladder physiology. She has a very, very effective and complex rodent model in bladder physiology, is able to look at a lot of different factors that go into dysfunctional voiding, has done well in translating that into applications in the human. It's a strong and thriving basic research lab. If residents have an interest in being involved in basic research protocols, then that is always available. And she also has collaborated with many of our clinical faculty to sort of do the bench to bedside process, where things that she and her team discover in the laboratory then immediately find translation into potential human therapies. And that's been something that we're very, very pleased and very proud of. And she really has built an extraordinarily strong basic research effort here in the division with multiple postdoctoral fellows and also mentors our MD faculty in basic research. Paul Maroney is the director of urologic oncology. Paul did his residency here, went to University of Indiana, did his fellowship in urologic oncology, came back here, has been here right at 10 years, is an extraordinarily talented surgeon, started the robotic surgery program here at the University of Colorado, was the chair of the robotic surgery committee. I'm gonna say Paul's actually been more like 12 years. I'm gonna give him a promotion there. Started our robotic surgery committee, still has a very, very high volume in robotic surgery, emphasizing mostly prostate cancer. Dr. Kukraj tends to emphasize more bladder. Dr. Kim does bladder and kidney. They all do a little bit of each of those, but those are their main areas of emphasis, with Dr. Barkawi also doing minimally invasive prostate. Paul's a great teacher, has won the Outstanding Teacher of the Year award on at least one occasion, has had multiple other awards for his teaching excellence from both residents and students. Extremely nice person, does just a great job in organizing and maintaining urologic oncology over at the Cancer Center. Janine Oliver is board certified in female pelvic medicine, reconstructive surgery, did her training at UCLA, is out here now, doing a really nice job teaming up with Brian Flynn. So we have two certified FPMRS specialists, interacts with Dr. Iguchi as well. Great teacher, really does a lot of complex female pelvic medicine procedures, including mesh reconstructions and prolapse and others. Someone that really very happy to have on the faculty, is a great contributor in that context. Kyle Rove, one of our newer recruits, been here 2 years, brought him on the same year that Janet Kukraja came on. Kyle also was a resident with us, went and did his fellowship in pediatric urology at WashU, Washington University, came back. Carl's wife, Jessica, was also a resident and did her fellowship in cardiothoracic surgery at WashU, and then came back and joined the faculty in that division. Kyle has a lot of expertise both in reconstructive pediatric urology, general pediatric urology, and also has a lot of expertise in information technology. So Kyle has a think it's a 0.25. It's a significant position with the IT infrastructure over at Children's Hospital, working with Epic, our EMR platform, as well as other IT projects, and brings a lot of expertise in that arena, both from a clinical perspective as well as a research perspective. Also a tremendously nice person, someone the residents really resonate with, and like a great deal. Kyle has a real affinity for Teslas, which is understandable. Went as far as to name his first son Elon. Don't know if those are related or not, but he is likes technology in all regards, including the car that he drives. Mark Sawyer is the chief of urology over at the VA. Is specially trained in endourology and urinary stone disease. Did his fellowship training in Vanderbilt, and then joined us at the university and at the VA. Mark is someone that really takes his job as chief of urology at the VA very, very seriously. He's a great resident advocate. Has done a lot to appropriately staff and organize that service over there. We actually have a fourth urologist coming on over at Denver Health in the relatively near future. I'm not going to say a whole lot more about that, because even though he is in the process of signing on, he hasn't actually started yet. Someone that I've known since he was a medical student, and a really great person, a great teacher. So that'll bring the ranks of our urology staff at the VA up to 4, in addition to Dr. Sawyer and Dr. Lloyd, and then Dr. Steinberg, who I'll get to in just a second. David Sobel is another urologist, along with Dr. DeRosa, who is at Highlands Ranch Hospital. His subspecialty interest is men's health, erectile dysfunction, hypogonadism, really nationally recognized in that field. Very, very innovative. Has a lot of very sort of cutting edge therapies for the management of those conditions. Regularly comes to grand rounds and contributes in that fashion, and is someone that I'm looking forward to having the residents rotate with at their facility at Highlands Ranch. Steve Steinberg does general urology, joined us from Arizona, where he was in community practice for 25 years, is just a great, great teacher. Steve is a gifted surgeon. He is, I'll kind of let the cat out of the bag. He's coming up soon for a very significant teaching award from our own program, and has received teaching accolades in the past. He's the kind of guy that residents say, he'll let you operate with a lot of independence. He's there to kind of keep you from getting into trouble. And if it looks like you're going to get in trouble, he'll get you back into the right path. And then he'll let you have your, sort of reign again until it looks like things might need a little bit of redirecting. So he's one of those people that is such a secure and such a confident surgeon that he's really able to let residents have a significant amount of autonomy, needless to say, all the time right there to make sure that patient care is optimal. But as someone that really does feel comfortable guiding residents without too stern a hand, so that they really do, they have the opportunity to identify where their own boundaries are. So Steve is someone that we all admire tremendously, and someone that, again, that we're extremely happy to have on our faculty at the VA. Dr. Vijay Vimalakanda is one of the other associate residency program directors, along with Dr. Kim. She's been in that position for about 10 years. Vijay is someone that, to describe Vijay, a couple of things I can say. One, she 2 years ago received a Rising Star Award from the American Urologic Association, and that's an award that's reserved for typically 2 junior academic urologists that really have demonstrated they are setting the tone for what it means to be successful in academic urology. And Vijay, we were extremely proud when she got that. Vijay, before she went to medical school, had other interests and graduated cum laude from Harvard Law School, and parenthetically has also chaired the Judicial and Ethics Committee for the American Urologic Association nationally. So Vijay is someone that's extremely diverse in terms of her areas of expertise, in terms of the areas of urology that she's really interested in and passionate about. She also has tremendous expertise in quality, safety, and process of care, and has NIH K-level research funding for 5 years, a full 5-year grant from the NIH, looking at process of care and using the EHR, electronic health record, to coordinate care between institutions among pediatric urologists. So Vijay is someone that I have a tremendous amount of admiration for. I really, again, rely on her heavily for administrative expertise and her wisdom and judgment in managing the entire division, and especially the residency program. So she, again, is someone who's just an extraordinary contributor. And then finally, Duncan Wilcox. Duncan Wilcox, I say the word amazing a lot, but I mean, there's like really not another word you can use to describe Duncan. Duncan was the chief of pediatric urology at Southwestern before you recruited him. Before that, he was the chief of urology at Great Ormond Street in London, which is where he was trained in pediatric surgery and urology. Duncan has been with us for about 10 years, just a bit over, was named the head of pediatric urology on his arrival, has since transitioned and is now the surgeon in chief. So he's in charge of all surgical services at the Children's Hospital of Colorado. An astonishingly good surgeon, just a tremendous surgeon in the performance of complex reconstructive pediatric urologic procedures. An unbelievably nice guy and someone that is just a delight to have. So Duncan is just an extraordinary success. Received, get this, 3 years ago, the Outstanding Teaching Award from the entire American Urological Association, so 25,000 members in 100 countries. And Duncan received the Outstanding Teaching Award. Pretty amazing if you think about it. So that's just one more accolade for Dr. Wilcox. This is me wearing my yellow cap. Beside me is Rich Schulich, the chair of the Department of Surgery. Rich came to us from Johns Hopkins, has been chair about 7 years. I put this slide in here to point out that we are a division of the Department of Surgery. We have 26 MD faculty. Department has about 200. That has been an extremely, extremely good relationship for us. I've been the executive vice chair in the Department of Surgery for about 15 years. The collaboration we have with them has been extremely helpful for us. When there's something we need, when there's something we want from the health system or the medical school, we speak as a division or department of 200 rather than just a division of 20, 23, 26, 26. Dr. Schulich has been extremely supportive, and that's working very, very well for us. So I would foresee us staying part of the Department of Surgery rather than being a separate department for the foreseeable future. We've been very successful that way, and I think we've actually accomplished a lot more than we would if we didn't have that very close collaborative arrangement. This was a bad year, 2015. It rained, it snowed. It was like 30 degrees up on the top of the mountain. So everybody there is all bundled up. It was fun, but we were all really happy to get back off the mountain that year and get back down and start drinking beer because that was a really, really cold day. This child actually did not carry that dog all the way up the mountain. It was a sort of a photo op thing, but it was a good climb, but it was, oh my gosh, was it cold. So I'm just going to say a couple of quick things. I want to leave plenty of time for questions at the end of this, but I want to say our primary teaching hospitals are the University of Colorado Hospital, the Denver VA Medical Center, the Denver Health Medical Center, and the Children's Hospital Colorado. This is the Fitzsimmons Army Medical Center. It's been now converted to the Anschutz Medical Campus. It was a 700-acre Army base. It was given to us by the federal government for like $1 as part of their base reclamation process. We have built a tremendous number of facilities, both research facilities, University of Colorado Hospital, Children's Hospital, the Veterans Administration Medical Center. And it's really nice because on one campus, we have 3 of our 4 primary teaching hospitals. Our Denver Health is several miles from here. It's about 8 miles away, but it's an easy, quick drive. Other than that, all of our teaching facilities are here on this campus. This is the University of Colorado Hospital. The University of Colorado Hospital, which is our largest teaching facility, it's the one that we had the most residents at one time, is continuously rated in the top 20 hospitals in the country by U.S. News and World Report. 690 beds, over 30,000 surgical procedures last year, almost 150,000 ER visits, 1.3 million outpatient visits, 49,000 admissions, and 506 organ transplants. The University of Colorado is a premier tertiary care hospital. We do an extraordinary amount of complex, reconstructive, oncologic material. I'm a male fertility specialist. I do have a very high volume microsurgical practice. We have a tremendous amount of stone disease. And again, reconstructive urology, female urology, urologic oncology. We also do a lot of routine stuff in terms of just general urologic procedures, hydroseals, TURPs. We probably don't do as much of that as we would if we were not as tertiary a hospital, but the VA Medical Center, Denver Health do a lot of general urology. And of course, we have everything from basic to complex pediatric urology at Children's Hospital of Colorado, consistently rated in the top 10 pediatric hospitals in the country, typically comes in 5 or 6. one of the highest rated pediatric urology programs, six pediatric urologists. We are soon going to be recruiting for a seventh. One of the largest programs in the country, has outstanding fellowship and also just an extraordinary volume of pediatric patients. Denver Health Medical Center, city and county hospital, large urban medical center, lots of trauma, lots of general urology, another one of our great teaching opportunities. And the VA, right down the street, about 300 yards away, 9 buildings, a regional center for veterans care, including the usual sort of VA-related urologic disease, which typically is a lot of prostate disease, bladder disease, renal disease. We also have a significant number of women as patients there, so female urology as well. A really, really good opportunity to see both basic and complex urologic care. I want to just touch on our resident research. We do have 4 months of dedicated research time, which is typically split up into 2 blocks of 2 months each, where the residents can do dedicated research for 2 months, go back to clinical rotations, come back to the research. We've found that the residents really like that. Gives them a chance to start a project, let it kind of move on a little bit, go do a rotation or 2, and then come back. The residents are involved in clinical activity as needed or as they're interested in at other hospitals, primarily the university. But we do set aside time where residents can do dedicated research. And our residents have been very, very productive. It's not as though they just do the research during those 4 months. We encourage them to get started in research year 1, focus intensely during that time, but continue those research projects throughout their residency. And they definitely have time to take advantage of those opportunities. I think one of the things you ought to think about when you look at a program is not just, is there dedicated research opportunity, but are the research residents productive in terms of what they accomplish? So in the last 10 years, the residents have published 61 peer-reviewed publications, 17 book chapters, almost 200 national and regional presentations, which would be the Rocky Mountain Urological, the South Central section of the AUA, other sections, American Urologic Association, National Oncologic meetings. We provide the residents with $2,000 per year to travel and go to academic meetings. We've had to curtail that somewhat this year because this COVID-19 thing has just thrown the medical school into a situation where they have had to really drastically restrict the funding for about a 1-year period. I think it's actually going to be less than a year. So we're still trying to work out how that funding is going to go this year. We'll be back to normal soon. And our approach is $2,000 a year for academic activities, for travel specifically, to go to meetings, give presentations. And it's something we're very proud of and something the residents have really accomplished a lot in. Last couple of slides during the resident research rotation, again, 2-month blocks. The residents we work with them to identify a primary research mentor and identify somewhere between 2 and 5 research projects. 2 to 3 is probably more realistic. But if they're short projects and they have a good definition of beginning and ending, they may actually be involved in more of that. We ask them to identify their mentor and their projects at least 2 months ahead of time. And then there's an agreement that the residents, the mentor, and the director of research, who's Dr. Vimala Kanda, come up with, outlining what the projects are, what the residents' identified responsibilities are, what their mentor is responsible for. And then the mentor meets with them at least twice a week, every 2 weeks. And they, during those mentor sessions, they discuss the project, they discuss what progress they're making, they discuss what the process of research is during their clinical rotations. They continue to meet with them to make sure that the research just doesn't kind of come to a stop, that they work with the residents to keep the effort going so it'll be there for the next block, and also to make sure that there's follow through to get publications and presentations. Because again, many of our residents will go on to do fellowships. At that point, it's very different to have said, I did a research project and I have 2 publications and 3 presentations, rather than just, I was involved in research, but we didn't really get anything published. Because the metric for how much you accomplish in research, for better or for worse, is oftentimes really what was your productivity and what do you have that you can point to and say, this is a citation for the work that I did. And again, our goal is for every resident to have at least 2 projects where they're the primary author on either publications or peer-reviewed abstracts, at least 1 submission to a regional or national meeting, and at least 1 primary author peer-reviewed manuscript for publication, most of which actually will end up getting published. And then we have the residents give a urology grand round presentation at the end of the research year to let us know what it was that they were working on and what the outcomes and the progress was. I will just say as an aside, when people say, so are you training urologists in your program to be academic urologists, to be community urologists, what's your goal? I would say this, and I've given this a lot of thought over the years, and our faculty have as well. When one of our residents decides to do a fellowship or not do a fellowship, but does go into academic urology, we like it. It's fun. You sort of like to see people do, the kind of stuff that you did. It sort of validates your own choices. And we're proud of them, and we love seeing them at meetings and continuing to work with them. However, 90% of urologists will go into community practice, not academic medicine. And if we have a resident or residents that go into community practice, as long as they go into practice and they feel that they received the kind of training they need to do a really good job and to be confident and to be happy and to love the work they do, we think that's a tremendous, tremendous accomplishment and a great victory. So we're not here to either train academic urologists or community urologists. We're here to give people the tools that they need either to pursue an academic career or a community career. And the majority of residents, when they start, they don't know which of those settings they want to practice in. We just want to make sure that they're comfortable doing whichever thing they choose. Finally, here's Ronan the Wonder Dog saying, thank you for joining us today. And I want to say that as well. Thank you very much. I know you've all got busy schedules. I know you have a lot of programs you're looking at. We are delighted, really delighted to have you spend time with us. And we're grateful for the opportunity to help you get to know our program. So I'm going to open this up for questions. I am going to demonstrate my technical prowess by stopping the screen share and going back so we can see everybody now. I will say in the background is an 800-acre property that I own about 30 miles east of the medical school. If anybody comes here and they want to go hiking or camping or whatever, you're welcome to use the property however you like. Just don't scare the deer. There's a whole bunch of deer out there. My dogs scare them plenty. So what we're going to do is open this up. We've got all kinds of residents I see here. We've got a couple more faculty members. We've got our residency, their residents are waving. It's like Exhibit A. Dr. Higuchi's here. We'll answer any questions that we can. And that's pretty much it. So you can chat or you can't really do the raising the hand thing because we have 4 pages worth of people and I probably wouldn't see you. But if you have a question, just send it in. I'm going to ask Dr. Higuchi to moderate that and maybe read the questions aloud as he sees them come up.
Sure. So we have a question from, I'm sorry, I might butcher your name, Divon Walker, asking about what is the progression of autonomy like for the residents during surgery?
Yeah, that's a great question. It's something we struggle with. I spent 6 years on the residency review committee for urology on the ACGME. I chaired it for 3 years, and we struggle with that. It's a balancing act. We want residents to be able to have the autonomy they need to feel and, in fact, to be competent to perform all urologic surgery or all the urologic surgery that they choose to do by the end of their training period. There are probably going to be some cases that residents are not going to opt to do when they go into practice, and that might be something like an incredibly complex reconstructive procedure, the kind of thing that Dr. Higuchi seems to makes easy, but I would just be scared to death trying to do it. There are always going to have to be questions on the really complex cases of what residents want to do when they're in practice, but we want to transition them from being beginning urologists to feeling comfortable to doing the vast majority of their own surgery, of their surgery when they leave. So what we do is, starting from the very beginning, we work with residents on their skills. We assess their skills and discuss with them the areas we think they have the greatest room for improvement and the things they've already hit the benchmarks we expect for their year. And we do that as they progress through the residency. We are always mindful of the need to make sure that the residents are not in a position where they feel like they don't have adequate supervision. Dr. Higuchi can probably attest to this, but when I was in a residency, we had a large city and county hospital, and we just never had attendings at night. We had gunshot wounds, we had MVAs, we did probably serious damage to people that didn't deserve that because we just didn't have enough supervision. We will never put a resident in a position where they don't have extraordinarily good supervision, both for their benefit and for the benefit of patient care. But they progress through the steps. We assess the residents twice per year during what's called the Clinical Competency Committee. We look at feedback from the attending and also from the fellows. We identify areas for development and we focus on those. And as the residents pick those up, they're given greater autonomy. So you'll never be in the operating room by yourself. We will, however, give you the opportunity with direct observation to go as far as you can. We'll help you move to the next level and let you pick it up from there. I'm going to ask Jeff Marks. Is that you, Jeff? I'm going to ask you to comment as whether I made that whole thing up or whether in the 4 years, the 3 years you've been in urology and the 5 years you've been here, if that sounds like we're hitting the mark on that one.
No, yeah, that sounds great. It's pretty well laid out by the ACGME, specifically for urology as well. I think we just had the grand rounds where we literally went through like what a level 1 resident looks like, and it's for open cases, it's for endo cases, it's for robotic cases, and we went through all that, sort of where you're supposed to be at. And when Dr. Meacham talks about those 6-month meetings, you go through all your reviews, and it's specifically for, like your open cases, like where are you graded on an aggregate level from your attendings, and where are your peers, and where should you be? So I think, we get that immediate feedback. I think, the urology department here does a great job. You talk about sometimes at other places, people will say, oh, this is a chief level case, or, oh, this is like a fellow level case. We really don't have a lot of those. I feel like the attendings are really, really good at accepting sort of more junior level residents in some bigger cases, and things that we think are bigger cases, or that people think are bigger cases at other places. We're just like, oh, this is
typical Thursday.
This is a Thursday, So it's like, I feel like we really do breed autonomy, which is good. And then, the other thing is, you talk about when we're on call, learning how to take calls, obviously something that you're going to have to be able to do, as a, urologist or practicing urologist. And I feel like, really from the get-go, we kind of incorporate you into those decisions, and we try to give you a lot of autonomy, and try to just, obviously the attendings are there to help out and make you feel comfortable. But I really do think it puts you in the position to do a lot of those bedside procedures and a lot of those things pretty early on that you otherwise would, have a chief doing or something like that. So I'd say we do a pretty good job. It's obviously a slow, long process. We all wish residency wasn't 5 years or 6 years or however long it takes. But
for Jeff, maybe it'll be 7. You never know.
You never know. But I do feel like we make nice steady gains, if you will, in terms of autonomy. And I very rarely have ever felt that scared or worried about something. I feel like I've always had pretty good backup if I get in over my head or something like that. And then obviously, with stuff in the OR, there's always the attending like either around. I mean, they have to be there for the timeouts. Like, not legal for them not to be, there. But certainly, they kind of, as you get older, they let you do things, and while they watch you, or they'll go do another part of the case while you're doing this. So I think it's pretty good.
Hey, Valeska, take the mic away from him.
Seeing us now.
So I'm going to say, it's saying that it's 5:59. I'm having like way too much fun to stop this right now. So since I don't think the Zoom shuts down exactly, we're going to go a little bit longer because we've got some questions and we're just kind of warming up here. So, hopefully you can stay with us for a little bit more. I'm now like taking control here, Ty, because I see the chat. Is it okay with if we next go to the urology? So let's go to call, and we'll just take them in order if that's so. Is that okay with you, Dr. Higuchi?
Yeah, and just for your info, Andy accidentally asked where the residents were in the resident room, because they've graciously said that they would be happy to stay on once all the faculty leave and answer any questions that the students have, without the parents watching. So they said they'd be more than happy to do that for an extended period of time. So Noel, if you can maybe make Jeff Marks or Valeska the hosts, they can take over the meeting once the faculty exit.
That'd be great. So then let me do this. Let me look at a couple, because they could answer like what the call is like for the residents, and they would probably want to be, really candid about that. Here's one that says there are a lot of urology subspecialists on the faculty. Could you discuss a little bit more how residents get exposure? We do so dedicated rotations and subspecialties. I'm actually going to ask Dr. Higuchi to comment on that. So certainly when you're at Children's, you're doing nothing but pediatric urology. The 3 adult hospitals, it's more intermingled. We have developed a team system at the university where we sort of subdivide in terms of clinic and OR. And Ty was one of the ones that really brought that into existence. So Ty, can you make a couple of comments about that?
Yeah, so what we have at the university to get subspecialty exposure is we have, it's a very generic Team A and Team B. Team A is the reconstructive team composed of myself, Dr. Flynn, Dr. Oliver, our fellows. I think Dr. Meacham on there, should he admit one of his VVs. He's never done that in past.
Let us hope I do not have to admit the vasectomy reversal.
um, and what the residents, we have 3 residents assigned to our team. What the residents have done in a very smart fashion is they'll assign 1 resident per week to 1 attending, which I think really increases their exposure to us. Like this week, I have Jeff Marks with me. He can talk a little bit more about all the stuff he did in this massive cancer surgery we did this today. So that's on our team. And then on team B is the oncologist, Dr. Maroney, Dr. Kim, Dr. Kukrasia. And again, 3 residents assigned to that. And they basically will divide the cases and how they cover the clinics. So that's how we do our subspecialty exposure.
I'm going to answer one question myself, and then I'm going to ask, I'm going to ask Dr. Majdi Islam to see if he thinks that I'm blowing smoke in this or not. Majdi is about to become a chief resident, is signed up to do an infertility fellowship. I'm so proud. An infertility fellowship when he's done with actually one of our former residents, who is now one of the premier fertility specialists in the country. It says, what do you, let me think here. I had it a second ago. Well, what kind of qualities do your residents attending physicians look for in incoming interns? I'm going to answer this for myself, because I've given this a lot of thought. You know, it's interesting. The applicants that we get and that we interview and they work with typically have just extraordinarily accomplished backgrounds in terms of their academic work, in terms of how they've done with sort of evaluable metrics. What I've been looking for, what I personally have been looking for in all the faculty members I've hired, which is all the faculty members we have, and what I personally look for in residents, is someone that is willing to put the welfare and the success of their colleagues at least on a par with their own success. And that it may sound kind of hokey, but I honestly mean that. Medicine is a complex and challenging business. Being a resident is a challenging and complex proposition. Being in practice is challenging as well. There'll be plenty of opportunities for you to need to rely on the people that you're with, the people that you're working with, to be there for you, and vice versa. I think we have done really, really well at the faculty level of hiring people that are very, very concerned and very interested in the welfare of the residents and each other. And it's trickled down and it's also part of what it looks like when we're hiring residents. So I would say someone that's willing to put the good of the group, but the good of the other residents and the faculty, their other faculty members, at least on a par with themselves, if not ahead. It's worked really well. I think we've accomplished a great deal more than we could have accomplished if that wasn't something that we really, really emphasize. I will tell you, occasionally we're wrong. We'll find somebody that's sort of out for themselves a little bit, but it's interesting when they come in and sort of see what the culture is, that kind of tends to fade. And they will suddenly sort of get the idea, they understand that what we're really looking for is people to be very, very supportive. And it's actually worked out really well. So Majdi, is that sort of how you view the way that this whole thing is unfolded? Or again, was that just sort of a marketing piece that I should keep to myself?
No, not at all. I mean, other than, you know, the couple times that we might have messed up with people like me or Dr. Marks, I think we've done a good job of picking residents. No, I'd kind of echo what Dr. Meacham said to an extent. I think, you know, from a incoming intern med student standpoint, you know, a big part of it ends up being, you know, personality, people that I think that we work well with. I think it's again, this may be a kind of a generic answer, I guess, but I think it's across the board. You know, people are going to look for someone that obviously you are able to trust and that you're able to bring to the table basically, you know, a personality that you can work with and trust and have a good time with in the OR, because you're going to be spending a long time with that person. For example, I hear Dr. Marks and Dr. Gucci spent 10 hours during a case today. It's just Dr. Marks and Dr. Gucci. He doesn't have anybody else to talk to for 10 hours. So you better like that person decent well. But no, and then also in the middle of the night when you're getting calls, it's from you're calling your attending who at 3 a.m. for something that you have to tell them about, and A, they have to trust what you're saying, but B, they have to maybe not hate the person who's calling them in the middle of the night. Hate's a strong word, but no, I think a big part of it is picking someone that you trust, picking someone with a personality that you get along with, but also it's people that bring things that are a bit different to the table. I think we have a program that has a lot of different types of people and personalities and whatnot, which I think is important for us too, in terms of having folks that we, with a little bit of diverse backgrounds and personalities do. I mean, I think that's my take on it, Dr. Meacham.
Thanks. I couldn't actually spend 10 hours with Dr. Marks or Dr. Higuchi, and I am sure they could not spend 10 hours with me. Ty, let's do one more. I'll let you choose, or maybe two, and then we'll turn it over to the residents to spend time with the students that are on the line with us here. What do you think what should we do next?
Sorry, I was muted. There was one question about if we're going to offer a virtual acting internship. Basically right now I would tell you this, we're looking into it. I don't know if we'll actually offer one because we're also seeing what the Society of Academic Urologists sends out as far as the guidelines for doing the acting internship. So Dr. Kukraj and I have been in discussion with Dr. Meacham and Kim and Vemalakonda about this, but we don't know if we're actually going to do it. I think it looks promising, but again, we don't want to overpromise and then underperform for one of those, because certainly we definitely want you to get a good look at our program. So again, we're waiting to see guidance from the SAU also.
Good. I'm going to go ahead. I think this would be a really good opportunity to let our residents, and we're really happy the residents are here, so they can spend time with you. I'm going to summarize by saying the following. And actually, I'm going to go back and I'm going to share the screen again. And I'm going to click on this. Are you seeing this big questions thing here? So the University of Colorado School of Medicine is basically become sort of a small city. I mean, in the foreground is us. The background is Denver. So we have really grown into a huge metropolis in a really excellent academic facility in a very short period of time. What I will tell you though, and I'm going to go ahead and unshare my screen now. What I would tell you though is the program has grown about fivefold. When I took over 20 years ago, I had 5 faculty. Now I've got about 25 faculty, but we still have never stopped emphasizing being a program where we feel like we succeed based on the success of the people that come through here. What sets us apart from people in the community, what sets us apart and maybe we think makes us special is providing extraordinary educational opportunities. We've gone from 2 residents a year to 3 residents a year. I would be surprised if in 5 years we haven't gone to 4 residents a year. Our faculty is extremely cohesive. They're very supportive of one another. We do extraordinary work clinically, but our primary goal is to arrange an environment where when people finish this program, they have the confidence, they have the skill, they have the self-assurance to do any kind of urology that they want and to be successful at it. And I'd say we've actually been really successful. We get feedback from our residents on a very regular basis. They become leaders in their own communities, both academically and in community practice. And we're really proud of what we've done. We're really pleased, really grateful that you've chosen to spend time with us. And thank you for stopping by. Noelle, thank you for setting this up. You've done just a tremendous job. We're really grateful. Dr. Higuchi, thank you for all the work you've done. Beth and Amanda, our residency program coordinators, thank you for being with us as well. So Ty, should we get lost and turn it over to the residents to sort of have a heart-to-heart about what it's really like to be here? You're on mute.
I'm on mute. I think that'd be great. And thanks to our residents. And I think it's a truly a reflection of the students. You know, they were invited to this meeting literally yesterday morning, and you'll see a lot of the residents are here. They're very dedicated to our program. They want to answer your questions. They really are the heart and soul of our program. And so certainly it's great to see them here, even though I did just spend 10 hours with Marks. It's okay. But yeah, thanks everyone for joining us. And please, we would love to see you at our grand rounds or our medical student education.
Definitely would. Okay, thanks. So the faculty are all going to leave. And I think actually, Noelle, are you going to stay? You're sworn to secrecy and you're going to help administer this. We'll have our program.
I'm actually going to leave as well.
You're going to leave as well. Okay, it's double
Yeah,
time.
I'll stop the recording and you guys have a private room to discuss whatever you guys would like to discuss.
Okay, thanks everyone. It was great to see you. Appreciate you being here.
Oh, no.
Oh boy.
Oh boy.
This is going to be great, guys.